as the two major labs on them. Since they're done by the same machines, you get them at a discounted price. I pay about $10, maybe $8 to $10 for a comprehensive metabolic panel. They would charge a patient probably $50 for it. Insurance would probably pay about $20 for it. CBC with diff, probably about the same, and charge me $5 to $10. Probably charge the patient $40 to $50. Insurance probably pay about $20. So the comprehensive metabolic panel is basically the glucose, the kidney tests, and the liver tests. Nowadays, they often include an estimated glomerular filtration rate, how well your kidneys are working. So the first is glucose, your serum blood sugar. It is in milligrams per deciliter, and the normal range is 74 to 109. There's a lot of various opinions on what constitutes diabetes. I think the technical would be 2 separate fasting blood sugars over 2 days or more, in which the fasting glucose is over 110 to 115 milligrams per deciliter. When I started practice, it was actually 2 checks over 125 milligrams per deciliter. The endocrinologists have kind of tightened that up some. As a side note, we generally use hemoglobin A1C, which is a check of the blood sugar that is non-enzymatically linked to the A1C molecule on hemoglobin of the red cells. Since the red cells last about 90 days, that will give you a thumbnail sketch of what your blood sugars have done for the last 3 months. The A1C should be less than 5.7. That's considered normal. 5.7 to 6.4 is considered pre-diabetes. 6.4 to 7.0 is considered diabetes controlled, and greater than 7.0% is considered uncontrolled diabetes. Okay, so going to the next, BUN, blood urea nitrogen. So our bodies break down nitrogen, and BUN is read as milligrams per deciliter. 6 to 23 is normal. So if your kidneys aren't working well, your BUN will tend to be high. If you're dehydrated, your BUN will tend to be high. If your blood pressure becomes very low, and that low volume affects your kidneys, that will make the BUN high. If you have a major insult, like you have trauma and a large hematoma, as that hematoma resolves, it will make your BUN high. Creatinine is a breakdown product of creatine in muscle cells, and it is from 0.4 to 1.2 milligram per deciliter. So creatine is the major thing used for calculating your glomerular filtration rate, your age, your creatinine. Creatinine, if it's over 1.2, you have some degree of renal insufficiency. But also, if you're an older person, let's say you're an 80-year-old woman, and your creatinine is right at the upper limits of normal, if you use the equation to calculate creatinine clearance, you're still going to have renal insufficiency, even though it's considered within normal limits. Then the electrolytes. Sodium, it should be from 136 to 145. Of course, with a concentration, the sodium could be low because you don't have enough sodium in your body, or you have too much water that dilutes the sodium. And same thing with hypernatremia. A high sodium could be you just don't have enough water. Probably the most common cause for hypernatremia would be an older person in a nursing home that doesn't have access to water to drink, and they get hypernatremia, altered mental status. But also you can have problems with the brain or the kidneys with concentration causing that. Potassium. So potassium should be 3.6 to 5.4. Again, low potassium is most commonly found with diuretics. If you take Lasix or hydrochlorothiazide, it can make your potassium low. If you drink excessive amounts of water, that can make your potassium low. Many other medications can cause low potassium. High potassium is most likely caused by having too much citrus or having renal insufficiency. So you can't excrete the potassium fast enough, and it increases in the serum. Chloride, it's from 98 to 107 millimoles per liter. It's not considered as significant as sodium and potassium. It doesn't, affect the cells as much, making the heart have arrhythmias, etc. But it is a calculation. The sodium minus the chloride plus the CO2 should be around 12. That's called the anion gap. And that's real important to deciding what's causing low CO2. So CO2, we used to call it bicarbonate. Now they call it CO2 combining power. If you think of CO2 as being the buffer to basically take down acid or treat, with CO2 going to bicarbonate plus a hydrogen atom, that's a way for your body to maintain homeostasis with respect to acid-base status. So the CO2 should be 22 to 31. If your CO2 drops down below 18, 19, then you probably have an acidosis. If the anion gap is high, that is over 12, that's a high anion gap metabolic acidosis. And there are certain things that cause that, a list that you will learn. So it pigeonholes it into a certain set of diseases. There's also hyperchloremic metabolic acidosis, which is another type. Okay, next, albumin. Albumin is a protein made by the liver that's in circulation. It's in grams per deciliter. It is 4.0 to 5.3. If your albumin is low in the serum, it generally means that you have a poor you have a poor nitrogen balance, or you have poor nutrition. So people with low albumin would be like older people who do not take in enough protein, or people with malnutrition. So if you think of albumin as being one of those entities that holds on to fluid, if you don't have albumin, the fluid's going to leak out of circulation. And that's why the kids have their real big bellies when they're during a famine. They don't have enough albumin in their circulation, and they get ascites in their abdomen and swelling in their legs because of that. And then you also have globulins. Globulins, like immunoglobulins, are also made by the liver. If you add albumin and globulin, that gives you the total protein. The total protein should be 6.2 to 8.2 grams per deciliter. The albumin to globulin ratio is in grams per deciliter, and it should be 1.2 to 2.8. One other electrolyte we haven't gone over is calcium. Calcium, of course, is very important for many processes, including the muscles. It's in milligrams per deciliter, and normal ratio is 8.9 to 10.5. Low calcium, probably the most common cause, would be medications. Then the liver test. So the total bilirubin is a breakdown product of red blood cells. That pigment goes from a bright red to a brownish color, greenish color. That is the bile, which sometimes could see if you vomit up bile, or if somebody has bile that they put a stent in the common bile duct and suck out the bile, it will be greenish in color. It should be 0 to 1.2 milligrams per deciliter. A lot of people have a syndrome called Gilbert syndrome or Gilbert syndrome. And it basically means your bilirubin runs high, but your other liver tests are normal. It's kind of just like having blue eyes or brown eyes. It's just a characteristic of that person that they're slow to get rid of bilirubin, metabolize it. It doesn't really cause any problems. It's generally seen every year when that person has their physical exam. You'll see a high bilirubin and everything else normal. It generally runs right at the top end of normal, like 1.2 or something like that. So the normal for bilirubin is 0 to 1.2 milligrams per deciliter. So that's total bilirubin. They also have one called direct bilirubin, which is conjugated bilirubin. So they got conjugated and unconjugated bilirubin that you can determine certain liver problems based on that. Okay, and then liver function tests. So alkaline phosphatase, it tends to go up if there's blockage of the liver or the gallbladder. It should be from 25 to 129 international units per liter. So if you see increased alk phosphatase, think about some kind of blockage, with gallbladder, gallstones, acute cholecystitis being the most common. And then there are transaminases. That's AST and ALT. They should be 6 to 37 and 0 to 43, respectively. So these transaminases go up if you have hepatitis. Also, they tend to go up in fatty liver disease. So that's how we often pick up somebody comes in who's overweight. They have elevated AST and ALT. They're diabetic. Then we think fatty liver disease. So we want to look at their liver. Somebody who's drinking too much will most likely have elevations of the AST and ALT. So the old way was AST was SGOT and the ALT was SGPT. Somewhere about 20 years ago, they changed the name. So the way you can keep that straight is so please keep it straight. So AST and the GOT and please ALP and SGPT. So please. Estimated GFR, glomerular filtration rate. How fast do your kidneys clear your blood of nitrogenous base? It is in milliliters per minute per body surface area. And normal is greater than or equal to 60. So they have chronic kidney disease broken down into stage 1, stage 2, stage 3, stage 4, stage 5, with stage 5 being it's about time for dialysis. Lots of old people are in that stage 3, stage 4 chronic kidney disease. Their estimated GFR for stage 3A chronic kidney disease will be 50 to 60, and for stage 3B will be 40 to 50, and then stage 4 will be between 25 and 20 and 40, and then stage 5 will be less than 20 or less than 15, kind of depending on who you listen to. So with those two lab panels, you can determine a lot that's going on with the patient. And there's, comparison before and then having them come back, compare it afterwards is very important. And then you can kind of focus your diagnostic tests based on what these general tests show. Question.